Good day. Our topic for the day is your respiratory system. So for the anatomy overview, we will tackle about your upper airways, your larynx, the lower airways, and your gas exchange. So the nose and paranasal sinuses. So the nose and paranasal sinuses, they warm and humidify your inhaled air. It filters particulates via mucus and cilia, and it houses your olfactory receptors for smell, and it resonates chamber for speech. So your paranasal sinuses are air-filled spaces in the skull bones which help lighten the skull and resonate the voice and produce mucus that drains into your nasal cavity, trapping particles and contributing to airway moisture and defense. So we have frontal, maxillary, ethmoid, and sphenoid sinuses. Your pharynx is divided into three. We have your nasopharynx, oropharynx, and your laryngopharynx. So your pharynx is a muscular tube that serves as a common passageway for air and food, guiding air from the nasal cavity to the larynx and food or liquids from the mouth to the esophagus. So your nasopharynx, it contains your pharyngeal tonsil or adenoids. Your oropharynx is the middle region, and the laryngopharynx is the inferior region where we have the divergence point for your digestive and respiratory tracts. Your larynx connects the pharynx to the trachea and protects the lower airways by closing the epiglottis over the glottis during swallowing to prevent food and liquids from entering the lungs. So we have your thyroid cartilage, which is your Adam's apple, your cricoid cartilage, your epiglottis, which prevents aspiration, as I mentioned earlier, and we have your vocal cords, which is for your sound production. So the function of your larynx, it protects your airway during your swallowing. Next would be your trachea. So your trachea, also known as the windpipe, is a rigid but flexible air tube that conducts air between the larynx and bronchi. So it is kept open by your C-shaped rings of cartilage. So it is usually 10 to 12 cm tube extending from your larynx to your carina. So its inner lining has cilia and mucus secreting cells that trap dust and microbes and move them upwards toward your pharynx. So the epithelium in your trachea, it is your pseudostratified ciliated columnar epithelium. And now, your bronchi and the subdivision. So we have your primary bronchi, which is wherein the right bronchi is shorter, wider, and more vertical than the left. Then we have your secondary or your lobar bronchi, and we have your tertiary or segmental bronchi. And after your tertiary bronchi, we will have your bronchioles, then we have terminal and respiratory bronchioles, wherein the diameter is less than 1 millimeter, which lead to your alveolar ducts and your sacs. So the bronchial tree, we have 23 generations of branching from trachea to your alveoli. So the surface area increases exponentially towards your respiratory zone. Then next would be your lungs. So your lungs, your right lung, here in the diagram, we have three lobes. We have the superior, middle, and your inferior lobe. While your left lung, we have only have two lobes, your superior and your inferior, with your cardiac notch for your heart. So the apex of the lung extends above your clavicle and the base rests on the diaphragm. And the lung is um, enclosed with your pleura. So we have your visceral and your parietal. So your visceral pleura adheres to your lung surface, while your parietal pleura lines your thoracic wall. So the pleural cavity, the thin fluid-filled space, creates your surface tension. And now, let's go to your alveoli, which is the site of your gas exchange. So the alveoli are tiny, thin-walled air sacs at the end of the bronchioles where your gas exchange occurs, allowing oxygen to move into the blood and carbon dioxide to move out. So they are surrounded by a rich network of capillaries. So here in the diagram, we have here the capillaries. So um, the network of capillaries are lined with your surfactant. So your surfactant, it reduces the surface tension and prevents the alveoli from collapsing during your expiration. So what are the mechanics of your breathing? So we have your inspiration and your expiration. So your inspiration, it is the active process requiring muscle contraction. So the diaphragm and the external intercostals increase your thoracic volume. While your expiration, it typically passive at rest, and it is usually due to the elastic recoil of the lungs. So the forced expiration uses your internal intercostals and your abdominals. And now for your pressure relationships. So your atmospheric pressure is the pressure of the air around us, so about 760 millimeter mercury at sea level, and serve as a reference point for your breathing. So your intrapulmonary or your alveolar pressure is the pressure inside the airways and your alveoli. So it rises slightly above your atmospheric during your expiration and falls slightly below it during your inspiration, allowing air to move in and out. So your intrapleural pressure is the pressure in the pleural cavity around the lungs and is normally always slightly negative compared to your atmospheric and intrapulmonary pressure, which keeps the lungs expanded. If it becomes equal to your atmospheric pressure, then we will have your pneumothorax, wherein the lung collapse and the air enters your pleural space. So your pulmonary ventilation or your breathing follows the Boyle's law, which says that when the volume of a closed space increases, its pressure decreases, and when volume decreases, the pressure increases. So when the diaphragm and your intercostal muscles contracts, the thoracic cavity volume increases and your intrapulmonary pressure falls below your atmospheric pressure. So air flows into the lungs. So when these muscles relax, your thoracic volume decreases, your intrapulmonary pressure rises above your atmospheric pressure, and air is pushed out of the lungs. So what are the physical factors influencing your ventilation? So we have your airway resistance, alveolar surface tension, and your lung compliance. So for your airway resistance, your broncholar diameter is regulated by your autonomic nervous system. So we have your sympathetic, which causes your bronchodilation, and your parasympathetic, which causes your bronchoconstriction. Your alveolar surface tension, your surfactant, which is produced by your type 2 pneumocytes, reduces your surface tension. So it prevents your alveolar collapse and decreases the work of breathing. And for your lung compliance, the ease of lung expansion is determined by the elasticity and surface tension. So it reduces in fibrosis and increase in your emphysema. So these are the respiratory volumes and the capacities. So for every breath at rest, so that is your tidal volume, we have 500 ml. The inspiratory reserve or the forcible inspiration beyond the tidal volume is about 3 liters. And your expiratory reserve or the forcible expiration beyond the tidal volume is around 1.2 liters. And the vital capacity or the maximum exchangeable air is around 6 liters. So these are some of the non-respiratory air movements. So the cough, it is the explosive expulsion which clears the lower airways. So it's also um, a mechanism wherein we have mechanism for our body to clear out the airways. Also the sneezing, it clears the upper respiratory passages. The hiccup is an involuntary diaphragm spasm and glottis closure, and the yawn or the deep inspiration which stretches the lungs. Now for the gas exchange principles. So the Dalton's law states that each gas in a mixture like O2 and CO2 in air has its own partial pressure, and each gas diffuses in the lungs from higher to lower partial pressure, which means oxygen from your alveoli to blood, CO2 from blood to alveoli. Well, for your Henry's law, it states that the amount of gas that dissolves in blood depends on its partial pressure and solubility, which explains why increasing your PO2 with oxygen therapy lets more O2 dissolve into the blood, and why CO2 is easily removed. Now for your external respiration, the blood arriving at the lungs has low oxygen and high CO2. So your oxygen loads into the blood as it diffuses from the high PO2 in the alveoli into the lower PO2 in the pulmonary capillaries and binds to your hemoglobin. At the same time, your CO2 unloads as it diffuses from the higher PCO2 in the blood into the lower PCO2 in the alveoli so it can be exhaled. So that is your external respiration. While your internal respiration, it is the exchange of gases between the systemic capillaries and the body tissues where the oxygen unloads from the blood to the cells. Because your tissue PO2 is low and CO2 loads from the cells into the blood because tissue PCO2 is high. So this allows tissues to receive the oxygen they need for metabolism and to remove carbon dioxide as a waste product. So let's go now to the oxygen transport in the blood. So about 98.5% is carried bound to your hemoglobin in red blood cells, forming your oxyhemoglobin. So the oxyhemoglobin, it is bright red, which allows large amount of oxygen to be transported without greatly increasing the blood pressure or the volume. And a small amount, around 1.5%, is dissolved directly in the plasma. And this dissolved oxygen is what creates your partial pressure or your PO2 that drives diffusion and helps determine how much oxygen binds to your hemoglobin. So your oxyhemoglobin dissociation curve is an S-shaped graph that shows the relationship between your PO2 or your oxygen partial pressure and how oxygen is bound to hemoglobin or your O2 saturation. So at high PO2, like in the lungs, hemoglobin becomes highly saturated with oxygen, while at lower PO2, like in tissues, hemoglobin releases your O2 more easily. So the curve can shift right. So you have decreased oxygen affinity. Example, your fever, increased CO2, acidosis, or exercise. So more oxygen is released into your tissue. So your right shift, it enhances your O2 or your oxygen unloading at your tissue. However, in left shift, it means there is increased O2 or increased oxygen affinity. So example, we have your low temperature, decreased CO2, or your alkalosis. So your hemoglobin holds your oxygen more tightly. So in left shift, it enhances your O2 loading at your lungs. So that is your oxyhemoglobin dissociation curve. Now, for your carbon dioxide transport, so your CO2 is transported in the blood in the three main forms. So, a small amount is dissolved in your plasma, bound to your hemoglobin, as your carbaminohemoglobin, and mostly as your bicarbonate ions in your plasma. So, again, your CO2 and they have three forms. So one is that dissolved in your plasma, the second carbaminohemoglobin, and third are those in your bicarbonate ions. So this bicarbonate system is very important because it helps buffer your blood pH. So changes in your CO2 levels, like in hypoventilation or hyperventilation, can quickly affect the body's acid-base balance. Now for the neural control of respiration. So it is mainly handled by your respiratory centers in your medulla oblongata and your pons, which automatically set the basic rhythm of breathing and adjust the rate and depth as needed. So we have here your dorsal respiratory group, so that is your inspiratory rhythm, and your ventral respiratory group VRG in your forced breathing. So that is um, located in your medulla. And also in your pons, we have your pontine respiratory center. So we have your pneumotaxic center, which inhibits your inspiration, and your apneustic center, which stimulates your inspiration. So these centers receive input from your chemoreceptors, so allowing breathing to change with activities like exercise, talking, or voluntary breath holding. And what are the factors influencing your breathing? So we have your chemical factors and your neural and physical factors. So the one that can increase your CO2 are the powerful stimulus for breathing. So example, uh, intense exercise. Also, another chemical factor is your decreased pH, which is detected by your central chemoreceptors. And hypoxia or decreased O2, which is detected by your peripheral chemoreceptors, can also influence your breathing. For your neural and physical factors, we have your voluntary cortical control, or your example, your breath holding, your stretch receptors, and your emotional states, pain, and your temperature. So what are the respiratory adjustments, especially when we exercise? So the onset of that is very abrupt, and we have your neural anticipation with that. Then after the onset, we have the steady state, wherein the ventilation matches the metabolic demand And we have your chemoreceptor fine-tuning. And lastly, we have the recovery within there's a gradual return to baseline and there is an oxygen debt repayment in your tissues. How about for those mountain climbers? So we have acute response. So at first, there will be hyperventilation because of your decrease of your PO2 stimulus. And there will be increased heart rate and cardiac output and respiratory alkalosis from CO2 loss. And in chronic acclimatization, you have, especially for those really had um, into very high mountains like your Mount Everest, their RBC is increased secondary to the release of your erythropoietin, and there's a right shift curve, and there's an increase in your pulmonary vasculature density. And one of the diseases that we'll discuss in this lecture, which is very common in adults, is your COPD. And your COPD is divided into two. You have your chronic bronchitis and your emphysema. So for your chronic bronchitis, it is inflammation and excess mucus production. So it's usually um, heralded by your productive cough for more than 3 months in 2 consecutive years. So they are termed as your blue bloater because they have hypoxemia, cyanosis, and edema. On the other hand, we have your emphysema, wherein the alveolar wall destruction and loss of elastic recall is prominent. So we have your air trapping, barrel chest, and hyperinflation. So emphysema, they don't have your hypoxemia because they are termed as your pink puffer. However, they are dyspneic but still with normal oxygen saturation initially, and they go on into distress secondary to decreasing O2 supply. So your COPD, the most common cause of this is your smoking. So part of our nursing advisory for our patients is to stop smoking, especially for those who are in their middle age bracket. Another respiratory disorders, we have your asthma. It is a chronic airway inflammation and hyperresponsiveness. So your asthma, which is common in childhood, it is the signs and symptoms include your bronchospasm, wheezing, and reversible obstruction. The good thing in asthma, once you deleted the triggers such as your allergens, exercise, cold air, and stress, your asthmatic patients have uh, usual and ordinary day-to-day activities. So no need to limit their activities. No, so your asthma is it is a reversible airway inflammation. Common also in Filipinos, your tuberculosis, which is caused by your Mycobacterium tuberculosis. It can damage your lungs and it can cause granuloma and castrating necrosis. So the symptoms of the TB usually have cough, persistent cough for 2 weeks with hemoptysis or coughing out of blood with night sweats and weight loss. So for TB, we usually give 6 to 9 months of anti-TB meds. And lastly, we have your lung cancer, secondary, 90% secondary to your smoking. So we have the small cell and non-small cell. So it is usually late in diagnosis and the symptoms appear after your metastasis. So your smoking not only causes COPD and a number of diseases in your body, it can also cause lung cancer. And lastly, for the developmental aspect. So the respiratory diverticulum bud is formed from your foregut endoderm at 4 weeks. And by week 5 to 16, your bronchial tree forms and there is no respiratory function yet during your pseudoglandular. And your canalicular or week 16 to 26, we have here the respiratory bronchioles and alveolar ducts are formed. Then in your saccular weeks or at week 26 and until birth, your type 2 pneumocytes or type 2 cells produce your surfactants. And your surfactant is needed to decrease the surface tension. And in your alveolar or late fetal to 8 years, the alveolar mature and proliferate and your lungs fully functional. So in premature infants, they lack your adequate surfactant. So especially for those premature babies. So it can lead to your respiratory distress and we have to give exogenous surfactant for those preterm babies to survive. So that's end our respiratory system lecture. Thank you for listening.